to introduce Mandy Trolinger. She's a master prepared dietitian and works for the Rocky Mountain Kidney Care, where she educates and counsels patients with CKD and provides medical nutrition therapy. She's also a big-time volunteer for the National Kidney Foundation and Renal Support Network. She's written several articles and is a dynamic speaker at national meetings. We're so excited to have you here today, Mandy, to help us learn about the side effects of dialysis. Welcome.
Thank you, Gail. I'm going to switch over and share my screen here real quick. I'm happy to be back here at Hope Week with the Renal Support Network, so it's always a true honor. It's an amazing group, a fun group, and they always give a great twist on learning and making it fun, even though it's not always on topics we want to really discuss at times. So I am going to talk about the top side effects of dialysis today. And the ones I'm going to focus on are fluid management and how this can affect several different things, which also ties well into sodium or salt monitoring, restriction, etc. And then we'll touch on itching, and then just a brief touch on cramping, and then focus on restless leg syndrome. And a lot of people that are currently on dialysis or have been on dialysis have probably experienced some of these. I know I have in the past. I am a 2-time kidney transplant recipient, and I was on hemodialysis for a bit, and definitely tried out a few of these, not voluntarily. So the one thing I want to go over is just kind of a few terms. And so something called target weight or dry weight. Everybody probably has heard of this that is on dialysis. They might not truly understand what it is yet, especially if you're new. And dry weight was a term that we used for a long time. And then a few years ago, another term came out as target weight. Essentially, they're kind of used interchangeably nowadays. And dry weight is the weight of a person without extra fluid on board. So when you're doing dialysis, hemodialysis, when you come in and weigh, and you have that, 2 to 4, whatever pound weight gain in a day or two, that is mostly fluid. And that, when we set your dry weight, that's what we're trying to pull you down to. So target weight means the same thing. So you will see those on reports or hear people talk about that. And that is the weight, the goal weight that we're trying to get to. And as you probably know, that weight changes a lot too. So water weight versus true weight, like I mentioned, water weight is weight that comes on quickly. If somebody gains 5 pounds in 24 hours, that is mostly water weight. True weight or real weight does take longer to gain. So if you gain 5 pounds in 2 weeks, then yeah, that might be more true weight than water weight. So that fast weight gain in a short amount of time is usually mostly water. And as most people know, in dialysis, we usually weigh everybody in kilograms. And I get this question a lot, like, what is that? What is my weight in pounds? So here is the conversion. It is 2.2 pounds per 1 kilogram. So we usually don't want people gaining for hemodialysis more than 1 kilogram a day, or about 2 pounds a day. So weight gain goals. With hemodialysis, most people will be restricted to 1 quart or 1 liter. It's pretty similar volume-wise. And that does equal, 1 liter equals 1 kilogram of weight. So if somebody has no urine output, usually they can get away with drinking 1 quart or about 1 liter of water or fluid per day and still stay within that weight goal as far as water weight between treatments. If they do have urine output, then however much your output is, you can add that as extra fluid you can take in. With peritoneal dialysis, because that is done every night or every day, every 24 hours, you're getting a treatment, that fluid intake isn't as restricted. So most PD patients can drink a little bit more, probably on average of 1.5 to 2 quarts of fluid per day, just because they're getting that dialysis every day. However, with home hemodialysis, if you are getting more dialysis, that does kind of lift a little bit on the restriction as well. So that is a nice, I don't know if I'll say perk, but a little stretch as far as the home dialysis modalities or methods, if you're a candidate for those. So speaking on fluid a little bit more, and hemodialysis, a lot of people have heard the term rinse back. And I get a lot of questions like, what is rinse back? And when they're setting up the machine, there is the saline that we use to prime the machine. And at the end of the treatment, if you look at the lines, they turn from red from the blood to clear almost. And that is the saline that we have to give back to rinse back the blood. And we calculate that in how much fluid we're going to remove. So if somebody's gained, let's say, just keep it simple. Let's say they've gained 1 kilogram since their last treatment. So they come in, our goal is to remove, because 1 kilogram of body weight, which is about 2 pounds, remember, equals about a liter of fluid. And so we want to remove that liter of fluid. However, most dialysis units will use a range of about 300 to 500, sometimes a little bit more, milliliters of rinse back of saline. And to give you an idea, a cup is 240 milliliters. So it's more than a cup that we're rinsing back. So since we're giving that fluid, we have to take it back as well. So if we're giving 500 milliliters of fluid and we're taking off that other liter, which equals 1,000 milliliters, I'm getting a math lesson today too. Sorry, there goes my computer. Okay, there we go. Let me get it connected back here. Technical difficulties. So with that being said, we would want to remove 1.5 liters, because we have the 1 liter of fluid and the half of the rinse back that we're removing, the total goal for a hemodialysis treatment. So the goal is, again, gaining no more than about 2 pounds a kilogram a day. So between Monday and Wednesday, we don't really want to gain more than 2 kilograms. Over the weekend, you have that extra day. So you don't want to gain more than about 3 kilograms, or about 6.5 pounds. Again, if no urine output, the restriction for hemodialysis is usually about a quart of fluid a day. If you're on peritoneal dialysis, again, about 1.5 to 2 liters is probably the norm that fluid restriction is set at. If we need to pull more fluid, where with hemodialysis, we just set the machine on how much water to pull. With peritoneal, it's the bags of fluid, the sugar water. We change that concentration, and that pulls more fluid. So different methods depending on the type of dialysis that you're on. Okay, moving on to too much fluid. So when there is an abundance of fluid, or this term is called hypervolemia, that can lead to high blood pressure. It can also lead to large blood pressure drops during dialysis, as well as making the blood pressure bottom out or go too low. So I do see this if I have a petite person and we're removing, let's say, 2.5 liters of fluid, or about 2.5 quarts of fluid during a 4-hour treatment. If I have a small little 90-pound woman compared to a 200-pound male, a lot of times if I remove 2.5 liters of fluid on the smaller person, because they are smaller, I can see their blood pressure drop because we're pulling so much in a short amount of time. Or maybe a larger person tolerates it just fine. So this is why it is important in keeping fluid or weights at goal. And that goal can fluctuate kind of up or down on what somebody can tolerate. When somebody does have too much fluid on board, you can get short of breath. Some people get this on exertion when just getting up and trying to walk from one part of their house to the other. Another thing is when they lie down, they get short of breath. If somebody tells me, oh, when I lie down, I get short of breath, but that's the only time, that tells me right there, that is a key that this person likely has too much fluid on board and it's up around their lungs and heart, which is not good. And the term for this, if you see or hear that we use, it's called orthopnea. This fluid overload, the heart and the lungs do not do well if they're underwater or in water. So this can weaken the heart. This can make the left side of the heart larger, which can be reversed. There are several things that can cause that, but by getting the fluids back under control, controlling blood pressure, controlling the red blood cells or anemia, that can make that left side of the heart go back down to normal size. So sometimes this, or usually this is reversible, but it's never a good state to put the heart in or under that stress. Of course, swelling, you can get that. A lot of people will get this in their ankles or their feet or their legs. You can get it in your hands. You can wake up in the morning and have puffy eyes and your face just seems puffy overall. You can also store it in the abdomen, which gets tricky because you can't really see that. And we have a lot of empty space in our abdomen that can store fluid. And sometimes when we get to that point where somebody's short of breath, that's where it's like, oh, we need to take care of this right now. And I have some people that will push the fluid in their abdomen. They never have swelling, excuse me, in their legs or their feet. They just get it in their abdomen. And it's hard for us to assess. I have one patient who I've never seen swelling on her legs. And she actually was hospitalized twice because of fluid overload. When we did imaging, we saw all the fluid in the lungs. And so when she gets the slightest short of breath at home, she knows now to tell us. And we know, okay, we think she's losing real weight. We need to lower her weight and challenge and pull more fluid. And we successfully now have kept her out of the hospital for a while. But she's one of those tricky ones that she, for some reason, the slightest bit of fluid on her goes into the abdomen, up around her lungs and heart. So it's something you want to pay attention to, especially if you get short of breath. Shortness of breath can also be due to anemia and low red blood cells. But you always want to keep in mind too, is it the fluid? Has my weight changed? Am I eating the same? Have I lost real weight? And think about those things as well. If we're trying to take too much fluid off, and this can mean the amount, if we're trying to take 3 or 4 liters of fluid in a treatment, or if you've gained true weight and we're trying to pull you down too low on your weight, you can get cramping. And this is probably the number one cause, or the top 2 leading causes are those 2 things. And I would say most of the time cramping we get under control. We do have a few patients that for some reason they cramp and it's hard to figure out the reason why. But we'll talk more about cramping too a little bit later. So as far as fluid tips and managing those, I'm sure everybody has, or at least half the people on this call, I know I have my fair share of my designer hospital water bottle. These are great because they have the measurements on them, but you can buy a lot more or prettier ones out there. And this is a great way to kind of watch and monitor your fluid intake. But just remember, anything liquid at room temperature counts. So this means Jell-O. If we get really picky, it's yogurts, puddings, if you can squeeze those in on your diet. And so anything liquid, popsicles, anything frozen, ice. Something I always encourage people to do, especially because we have the ice chips at our unit. And a lot of people, if they fill a cup and they fill it all the way up, they're like, oh, if it melts, it's half of that. Well, when they're ice chips, I guarantee you it's more than half of that cup is going to be liquid. Larger ice cubes, obviously, when they melt, it won't fill it up. But if you have at home, sometimes I tell people, fill your cup up with what you normally use as far as the type of ice cubes, let it melt and see really how much fluid that is. Because I know a lot of people will just, kind of use ice to kind of suck on. Don't chew on it, because I know Cher on this call, she's a dental hygienist and she will get on to you about hurting your teeth and biting ice. So you want to always use kind of the same cups. That kind of makes it easier to know the volume of those cups and how much you're drinking. Smaller cups. I always like this idea because you have that smaller cup with your meal or whatever, and you know that's your amount. It kind of goes to that philosophy. I know we got rid of all the large dinner plates in our house because we never eat that much, or we shouldn't be. So we just use the small, like salad plates, and those are our regular plates. And so that has always helped me eat less if I'm trying to cut calories. So same thing as far as using smaller cups, like the little juice cups instead of the big, tall glasses. The other thing is following a low salt diet. Salt loves water, and when you do take in a lot of salt, you will become thirstier. And that also can cause cramping too if you're eating a lot of salt during dialysis when we're trying to remove the extra fluid. Some other tips are, some people will use like frozen grapes or lemons, even frozen blueberries. You can just kind of experiment with different fruits and you can kind of pop one of those out. And that sometimes can help quench that thirst. Brushing your teeth can also kind of curb that when you're wanting to drink more fluid. Gum, hard candies, those always work. Obviously, if you are diabetic, using the sugar-free ones. And keeping, if you are diabetic, keeping the blood sugars under control. High blood sugars will and can cause an increased sensation of thirst and will make you drink more. There are some dry mouth products out there. I think Biotene is probably one of the brands I see often, and they have different things as far as mouth rinses, toothpaste, gums, sprays, gels. I get kind of a mixed feedback from the patients I've seen try those. Some say they help some say they don't really do much. Obviously, limiting very sugary or very spicy foods. That can increase your thirst as well. And be careful with some of the drinks you see out there that say thirst quencher on them. A lot of these are going to be an electrolyte replacement. And with that being said, they're going to have potassium, they're going to have some sodium, and things we try to usually avoid. So be very careful and make sure you're reading the labels if you're drinking any of those. The other thing is with planning your day, because remember, the fluid restriction is like a quart of fluid a day. So if you have an event or you're going to be going out with family, out to a restaurant that evening, and you know you're going to be in a situation where you will likely drink more fluids, you want to be able to plan for that day. So earlier in the day, kind of just keep your fluid restriction down even a little bit more or more strict. And then you can have a little bit more to drink in that evening time. Okay, as far as sodium intake, we normally recommend less than 2,000 or less than 2,300 milligrams. You will hear both as far as how many milligrams of sodium to keep below during one day. That does equal about 1 teaspoon. And something I always tell people is if you look at your hand, so on the pinky, from that top knuckle, that, and everybody's hand is a different size a little bit, but roughly that is about 1 teaspoon. And that always kind of gets people. And then they're like, oh, wait, I can add that to my food? Well, no, because salt is in almost everything we eat, especially if you grab the grab and go or the shelf stable stuff, which we'll talk about. So that's where you really get rid of the salt shakers. Don't add salt to anything. Benefits of following a low salt diet is better blood pressure control. Some people are more salt sensitive than others. If it's somebody who is not on dialysis, but maybe is getting close to dialysis or even before, following a low salt diet has been shown to lower the rate of kidney failure before somebody starts dialysis. So it's something we recommend to all of our patients, and really everybody should follow a low salt diet. There's only one exception to that, and that's if you have low salt levels, and that's kind of rare, and that's a whole different issue. So pretty much everybody should follow a low salt diet. This will lead to better cardiovascular or heart and vessel outcomes. It keeps the vessel system healthier, especially, if somebody's being evaluated for transplant. You probably know, if you've gone through that evaluation, they do tests to look at your vascular or the vessels of your body and make sure they're healthy so they get enough blood and good flow to the transplanted kidney. So it's very important to keep all those vessels nice and healthy and happy. Low salt diet, again, less thirst and less cramping with dialysis if somebody's experiencing that. And it helps you keep a little bit, or make it a little bit easier on keeping the fluid restriction down, even though it's hard. That was one of my hardest things on dialysis, because we are told our entire life to drink, like just drink fluid all the time. And then the in thing, maybe 15, 20 years ago, probably more than that, everybody walks around with a water bottle. And that's where I remember seeing a physician round in a dialysis unit. And I was training, and he rounded in there, and he had his cup of coffee sitting on the table while he's rounding to the hemodialysis patients. And I just kept looking at it, and I'm like, here you are drinking right in front of a patient that we're telling them not to drink. And I know, being a patient, I had that perspective, and I know he didn't mean anything bad by it, but it's in your face everywhere. So this is a hard thing to control, but kind of by doing these things, this can kind of help. And these are kind of the reasons why long-term they are highly beneficial. Okay. So just to kind of review, the high salt, I kind of mentioned before, it can increase your thirst, therefore increasing your fluid intake. It can increase swelling, therefore the fluid builds up, causes shortness of breath and high blood pressure, and overall it starts stressing the heart. Okay, tips to lower sodium intake. I mentioned before, kind of avoiding those shelf stable or kind of quick grab and go foods, fast food as well, processed things like salami, bologna, hot dogs. All of those things are extremely high in salt, so you want to definitely avoid those. Some of the sauces or salad dressings, that's where a lot of salt hides. The good thing is sodium is listed on every label. I kind of tell people you're trying to follow that less than 2,000 milligrams. So if you're a 3 meal and a snack kind of person, then each meal try to keep it under 500 milligrams. And then you still have another 500 to give for snacks or whatever. Always going, especially for vegetables, go for the frozen or go for the fresh. Those, if you have to get canned, I know there's some people, you know, it might be due to cost or it might be due just to storage. If you have to get canned, if you can get the low salt, there are some low salt varieties, even though they're still high salt, rinse them off several times. And then when you cook them, dump the water you're cooking them in, and that gets rid of a little bit more salt, but they're still going to be higher than if versus frozen or fresh. Salt-free seasoning. So this is something, there are so many recipes on the RSN website as well. And some of the dialysis websites, they have a section on there and you can make your own salt-free seasonings. I mean, Mrs. Dash is a great one to grab and go get. But if you're like me, if you use that on everything, everything starts tasting the same. You want some variety. So if you go onto these websites, they have sections for sauces and seasonings, and you can even make some of these seasonings and just put them in a bottle of your own. And then they're there ready for you to use when you want. Using fresh herbs versus the dried ones. They have like those mini herb gardens where even they have their own light and you can grow your own, or you can just put some in some flower pots and put them in the window. The fresh ones have, the taste is so much stronger and it's a lot better than if you have to use the dried ones that are in your cupboard for 5 years or 10 years. I've talked to so many people who they'll find something that they rarely use and it's 10 years old. It's a little old, you know, the little tin cans of spices and seasonings. So definitely if you can keep those more fresh, it adds a lot more flavor. And I didn't think it really made that much of a difference, but I did try some fresh ones once, a couple times, and I noticed a big difference. It just tasted better. And so when I can, I like to use those as well. Salt substitutes are something that this comes up a lot because patients will see something called salt substitute and they're like, oh, I'll do that. It has a similar taste to salt. However, table salt is sodium chloride, where salt substitute is potassium chloride. So salt substitutes are basically the powder form of potassium tablets that we give people to increase their potassium. So I've had some patients where it was discovered their potassium was high, and somehow through the conversations between the dietitian or myself or whoever, we found that they were using salt substitutes. And that can definitely spike that potassium up. So that can be kind of tricky. If you're a peritoneal dialysis patient, sometimes it's the opposite. You need potassium. So I'll sometimes tell people, hey, you can use that. But with hemodialysis, that usually is not the case. So if you're thinking about trying salt substitutes, do discuss that with at least the dietitian or your provider before trying that to see if that is a safe alternative. I thought it tasted okay when I tried it. My husband said, nope, he would never use it. So it's definitely a taste preference there. Okay, so we draw a sodium level. Usually it's done monthly with labs for patients that are on dialysis. And one of the reasons for hemodialysis patients we do this is because a normal sodium level is about 135 to 145. You will find low sodium levels in a lot of dialysis patients, and in hemodialysis especially. The reason this is, it's not because you need to eat more salt. And you'll meet even a lot of providers or other specialties will don't have a full understanding of this because it's not their area. But I see that a lot of times. And then they come to us and we're like, oh, no, 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 no. What it usually is likely due is somebody has too much fluid on board or they're drinking too much fluid. So with a dialysis patient, especially no urine output, even just gaining that 2 pounds from that 1 quart of fluid a day, it can lower the sodium level. So I'll see most of my patients sitting some down to like 128, some in the lower 130s. And that's okay because we know it's more due to a dilutional effect from too much water, even though it's within the allowed amount. And what we do on that hemodialysis prescription, there are things that we have set. Like we do give you some calcium back. We do give you a little potassium back. And that's the bath. That was what we call the bath on the machine. And we have to give some of that back. Or you'll be feeling pretty bad at the end of a treatment. But the sodium is another thing that we set on that machine. And that level, what we've learned is we try to set the sodium level on the machine close to what the person's sodium level is. Because we have found if somebody's sodium level sits around 135, I don't want to set the sodium level at 140 higher on the machine because we have seen that that causes increased thirst and kind of can aggravate those fluid gains with the hemodialysis patients. So we try to kind of match it or get close as far as the sodium in your blood and the sodium on the machine. Back in the day, this is probably, I'm dating myself here now, probably at least 15 years ago, if not a little bit more. If a patient got cramping during hemodialysis or their blood pressure bottomed out or went too low, we would have a syringe of salt water, saline, and we would inject it into the machine. Well, it was great because it fixed the cramping, it normalized the blood pressure. And I was during the time, I got that a couple times and it did. It would, if you were cramping, it was gone. And it just felt like one of the few miracle drugs or breaks that you get on hemodialysis. However, later on, that we were actually doing damage, especially to the heart, which heart issues, that's the number one thing that gets our patients. And so that practice was stopped. So that's something we do not do anymore. But I remember the treatments that I would get that after treatment, I would want to go home and I felt like I just needed to drink a whole quart of fluid right then or there. So it was really a wake up that I could tell having that salt load and right after treatment, the thirst was excessive. So that's something we're not doing anymore because we've learned from that. But that is something a lot of patients don't realize is that we do have the settings on the machines and we do try to kind of match it. So again, the salt level, when it's too low on dialysis patients, and it usually is on the lower end, it's a dilutional effect from the extra water. So we do follow that. The peritoneal dialysis prescription, that's pretty much the same. There's a little bit of salt. I think I'd have to look on a bag. It's been a while. I think it's about 500 milligrams per exchange per bag in PD. And that's not something that they really alter in peritoneal. It's just hemo that this applies to mostly. So moving on to itching. This is something I definitely have a handful of patients ranging from mild to severe. I know there was other times, I think it was due to medication or something that I had itching from. And I'll tell you what, I would take pain over itching any day. It is one of the worst feelings you can have. Unfortunately, this is something we see in our patients. And the term for this is pruritus, is what we call it. And there's a CKD, chronic kidney disease associated pruritus. So this is something I have seen it in some of my patients that aren't quite on dialysis yet. So their toxins that the kidney cleans out, they're high. And then patients that are on dialysis experience this. And I tend to see this more in my hemodialysis patients than my peritoneal dialysis patients, but you can see it in both and patients that aren't quite on dialysis yet, but the kidney function's pretty low. It can be very tricky to find the exact cause of itching. There are several causes, and I'll be honest, this is one reason I would never work in dermatology. It's like a rash. Trying to find the source and the cause of a rash can be so difficult. Usually patients will complain that the itching is mostly on their back, but they can get it on their arms, head, abdomen. I mean, they can get it all over, but the back is the common place that I get this complaint, at least where it starts. It can be acute, which means it can happen just in short episodes, not all the time, or it can be chronic where it's all the time, during the day, during the night, can get worse at night, keep patients up at night. So then they're getting less sleep, which that just makes it hard to handle anything. Stress or heat can also increase itching. And we've seen once people start dialysis, sometimes we'll see that itching get resolved. And with that being said, we look at dialysis clearances and how well somebody's being dialyzed. So sometimes if we increase dialysis, which nobody wants to do, that sometimes will help the itching as well. And usually there are no lesions or no rashes with this type of itching if it is due to chronic kidney disease or end-stage renal disease. It's if there are lesions or something, it's usually because somebody's been scratching so much, they've caused some sores or some bumps and scabbing. But if it's due to dialysis, there's no rash with this. The other things you do want to roll out first is cholestasis, which is basically like if the liver's the trash dump of the body. It filters out a lot of stuff. And if the liver's backed up, that can cause itching without a rash. So that's something simple lab tests can look at that. It's rare that I'll find that though. I maybe have found 1 or 2 cases in my career, but that's more people that are not on dialysis that have itching. You'll find that a little bit more common. But in dialysis patients, it's rare that it'll be because the backup of the liver. The other thing, again, you want to rule out is if there's any hypersensitivity. So this would be any medication allergies, anything environmental allergies. So some of our patients will go to see an allergist and have extensive allergy testing done as well. Okay, so the first thing that we want to rule out is dry skin. And because on dialysis, we're removing this fluid, when a patient walks out, especially after hemodialysis, you're in a little bit of a mild dehydrated state. And that's just because of the intermittent, the 3-time-a-week dialysis, we kind of get you on that dry side. So dry skin is definitely something you want to address first. When you look at somebody's skin, it doesn't mean dry skin is when you see flaking. Dry skin starts way before that. So you really have to examine the skin closely. It's more than just like if you scratch your skin with a nail and you see a white mark, you're probably already in the moderate dry skin category. So you really have to look at the skin closely. High phosphorus levels. This is usually going to be up in the higher 6s and higher. You can get itching again, usually no rash, but there is itching. However, get the phosphorus controlled and the itching should resolve. The high phosphorus can lead to a high PTH. This is the parathyroid hormone. These are those small glands in the neck that can they get off balance because the kidneys don't work at 100%. High BUN. This is the lab test that shows the blood urea nitrogen. This is the toxins in your blood that your kidneys aren't cleaning out. So we test this usually once a month. For hemodialysis patients, they'll check it before your treatment and at the end. So patients come in like, I'd say normal, 40, 50, 60. And then at the end of their treatment, they're back down to around like 15, 20 or whatnot. Because after dialysis, we filter out some of those toxins and then they build back up and we filter them out. But when they come in really high each time, that can sometimes cause that itching. That's why some people that get itching before they start dialysis, they will have a BUN at 80, 90, some, over 100. And they get the itching, they start dialysis, that comes down, the itching resolves. So then we know, okay, the BUN, even though this is the toxin load, there are so many different toxins that we haven't even identified yet. And we don't know, like, why do some people get toxic or nausea and vomiting at 85, where others can be 105 and feel fine? So there are a lot of these toxins where I think if we can figure out all of them, we'll have a big key to like which one causes itching, which one causes nausea. But this is still a little bit of a mystery in kidney care. High calcium. The research, says above 9.5, but I'll be honest, I've never really seen the high calcium cause itching. It's usually when it's going to be really high, like 12, 13. But I've rarely seen this. High aluminum, that's not so much the case anymore. Most patients dialysis, they have an aluminum level drawn when they start. I don't know if they're doing them yearly at every dialysis center. Some are. And usually aluminum, that's going to be high if somebody's still using the old aluminum pans at home. I've had 2 cases in my career that we caught a high aluminum, and they both were using the old pans with aluminum, and it was leaching into their cooking. So it was an intake. High magnesium levels, with dialysis patients, usually magnesium supplements are not needed. They're not required. Magnesium levels are usually fine. However, I do have a couple patients that actually need magnesium supplementation. People that are on proton pump inhibitors, these are those drugs that over-the-counter meds for reflux. It's like the omeprazole, pantoprazole. Those can decrease your magnesium absorption. So I'll see low magnesium levels, but it's usually in patients before dialysis. It's not dialysis patients, but a high magnesium could cause itching. Not enough dialysis. And this is where we do a lab, and it's called the KT over V. Peritoneal and hemo get this done. It's usually drawn once a month. It's a big calculation that takes into account certain blood values, your body size, and it spits out a number. And so like for a hemodialysis patient, usually minimum goal is at least 1.2, but we usually like most patients at 1.4 or higher. And so if somebody comes in and their KTRV is sitting at 1 and they're complaining of itching, they are under dialyzed. They're not getting enough dialysis. And so that's where we'll increase the time or treatment frequency. And hopefully that would improve the KT/V and resolve some symptoms as well. I put bug bites on here because this is something I have seen more and more. And however, you usually will see a rash or something, but I've seen people that have been exposed to bed bugs. Bed bugs do not care where you are, who you are. It doesn't have to do with hygiene. I always tell my story. We were over in Hawaii and we were staying at the Marriott, and we got in like at 10 or 11 at night. And I always put all my luggage in the bathroom and look around the bed for the bed bugs. And one of the rooms, because I was with different family members, one of the rooms, lo and behold, we found evidence of them. And I loved it because the security guard comes up and housekeeping, and they come up and they're like, "We're at the Marriott. We don't get bed bugs." And I just started laughing. Like, do you think bed bugs care where they go? They are everywhere. We see them, in rehab centers. We see them sometimes in nursing homes. And so that is something to be aware of. And I just had a patient that came out of a rehab and she had been itching. And then lo and behold, we looked and we found little clusters of tiny bites. And so I'm pretty sure her itching is due to that. So hopefully we're letting that resolve and it solves it. But they can be very, very tiny. So you want to look for that, and they'll usually be in a cluster. Less common causes can be anemia, which is low red blood cells. Males tend to have this a little bit more. Heart failure, certain nerve disorders. Sometimes we need to look at those and resolve that. High vitamin A levels, although I haven't really seen that or found that as a reason. Ascites, and that's where fluid builds up in the belly and in the space it should not in the belly, but that's usually due to liver failure or another medical condition. So that's a very isolated situation too, because usually if somebody has ascites, their liver isn't functioning well, and those liver toxins are increasing, and that causes itching. So what do we do to help resolve this? The first thing we do, and we try it for 2 weeks, is try topical emollients. You want to look in the ingredients, and this is where it's important, is you want to try to avoid alcohol in the ingredients. A lot of the lotions, the emollients, true emollients, it'll be hard to find them in a pump, because usually when you put a lotion or moisturizer in a pump, you are putting alcohol in there to thin it out so it gets through the pump. So you want very low alcohol levels. When you're looking on the ingredient list on a product, the first product in that paragraph of ingredients is the one that is the highest amount. So you want to look like, you want water to be one of the highest ingredients on that. You don't want that alcohol or cetyl alcohol as the second or third ingredient on one. You want high water content. You want to look for the ones that contain paraffin or glycerol. And you'll see glycerol comes in all these different forms. So if you just look for that GLYCER in the ingredient list, you'll know you have a pretty good one. These are typically going to be the gooey emollients that are in the jar. Think like Vaseline, that kind of stuff. And they take a long time to absorb, but that's the best thing to try first. Try it for 2 weeks. If no improvement, then we can look at topical analgesics that we'll try for a week. And if that doesn't improve, we move on from there. The topical analgesics, though, that is more for like localized itching. So just spots of itching on the body. It's kind of hard to bathe yourself in a topical analgesic, and it's probably not healthy. But this is more for localized itching. And this is going to be kind of like your diphenhydramine or Benadryl creams. It's going to be that class. There are topical NSAIDs. These NSAIDs stands for non-steroidal anti-inflammatory drugs. You don't have to remember that. Just remember the NSAIDs, because that's also like, as far as pills, that's ibuprofen, Advil, Aleve, all of those, which kidney patients should not take because they can hurt the kidneys. Dialysis patients shouldn't take because they can cause ulcers and bleeding, which can lead to anemia. So there is a topical form of this called diclofenac, which is sold over the counter now. A lot of people use this for arthritis, and it does really help them. However, I caution, get approval if you need to use it. But again, it's for like a very small spot. This is not something that you could use all over for itching. So I do not recommend that. Capsaicin, so that's the spicy hot stuff. It's not really well studied, and a lot of people just complain that it caused like a burning sensation when they used it. So again, I want to make sure we have adequate dialysis. So looking at the KT over V, if we need to make adjustments there. As far as hemodialysis, it might be increasing time. It might be, depending on the body size, it might be changing the dialyzer, the size of the dialyzer on the machine. So most people are going to be using a biocompatible high flux dialyzer. That's pretty standard. But sometimes we can change the dialyzer. I've had a handful of patients that it was the dialyzer that was causing the itching. And so we changed them to a different one, and it worked. Sometimes we changed them to a different one for a week or two, and there was no change. So we just went back to the original dialyzer. So that's something, and usually that's going to come on when they start dialysis. That's usually not something that comes on years down the road. And it's one of the less common causes of the itching. So what do we do if none of that works? Definitely look at the labs again. Control the phosphorus, calcium, parathyroid hormone, magnesium. Some things like cooler temperatures. Cold showers, people tend to say help relieve a little bit for the moment. Some people say hot showers work, but sometimes hot showers can make it worse. Sometimes exercise, just kind of distracting the mind, helps. Antihistamine pills, again, this is going to be like the diphenhydramine / Benadryl tablets. They can, just be aware, they can make you a little sleepy. So we usually only try this for a week. If it's not working, we move on. Hydroxyzine is another one. This one, I will warn you, it does have more of a sedation effect. My husband, actually, he would get this itching on his arm. They still to this day don't know what causes it, but it just happens here and there. And they had given him some of that to try, and it would knock him out. So definitely, especially in older populations, we want to be careful with medications that can make you sleepy. One, driving or just walking and increased fall risk. So this is something we'll try it for a week, and if it's not working, we move on. We can then try some prescription medications. Again, these can have side effects as well. There's gabapentin and pregabalin. We will try this for 4 to 6 weeks and give it a shot. We're not seeing any improvement. Then we do not continue them because, especially in the elderly population, it can cause dizziness, tiredness. And especially with gabapentin, it has to be dosed where your renal function is, because with a lot of medications, they do not clear through the system as fast. And so they have to be dosed at a lower dose. So for example, with gabapentin, I have seen this, and I still see this to this day. An outside provider prescribes them this, where a person with healthy kidneys might be taking 300 milligrams 3 times a day and do fine on it. For a dialysis patient, that is very dangerous. We do not usually go over 300 milligrams total for the day. So we might do like 100 just at night or 100 twice a day. We stay at a max of 300 because with those higher doses, and I have seen this more than once, I had a dialysis patient and you have the needles in your arms, and during treatment, his arm would just kind of just jerk and move real quick and then stop. And then it would happen later. And when I saw that, I knew exactly when I checked his med list from the rehab center and I saw exactly what it was. We got him off the gabapentin, all that went away. So some of these medications these need to be really followed by nephrology, or if neurology is using them with a patient, it needs to be a joint effort because they have to be dosed lower or they can become dangerous for a kidney patient.
Mandy,
Yes.
can I interrupt you and just ask about the newer drug called Korsuva? Have you got any patients that have tried that?
I was just perfect lead in.
Oh,
I paid you for this.
I'm sorry.
So this is kind of where I was kind of excited because we do have this newer one. And a couple of years ago, I was actually at a dialysis center that we were involved in one of the research trials on this. And it is the name brand is Korsuva. I will let you, it's difelikefalin. I've heard it. I'm not sure that's the right pronunciation. I've heard people pronounce it a million ways. But the name brand is Korsuva. This is the new one out, and this has only been approved for hemodialysis patients. And it is given IV, so it's given on hemodialysis through the machine. And usually when we do this, we try it for 12 weeks. A lot of the people in the studies saw some improvement, if not huge improvement. And I had little petite, she was probably in her mid 80s, fiery lady. Like she was always a blast to talk to. And she had one of the worst cases of itching. Didn't start till right before she started dialysis. She started dialysis. She was adequately dialyzed. We went through all these other things and nothing even helped. And so then she was brought into the research trial on this. I could not believe the difference it made. And she had, I mean, it resolved it almost to minimum of symptoms. She still get a little itching here and there, but compared to what it was, her quality of life went just improved vastly. Her daughter always came to her with dialysis. She's like, she's in a better mood all the time. It was a huge improvement. So this drug definitely can work. I will say it's not 100%. I've had some other patients I've tried with it, didn't really do much, or it did a little. But this is something I will say it's not easy to just say, hey, I want this for my patient, and it's approved. It does have to be approved through the dialysis company. It requires, similar to like a prior authorization, we have to do a justification of, we've done this, this, and this. We've tried these other things. They haven't worked. And then if we can get it approved, I'll be honest, some patients I've had it approved and some people it's denied, which is frustrating because itching is a horrible thing and it affects quality of life for our patients a lot. But this drug has been the first thing to come out in a long time, really in my career. It's the only change as far as diagnosing itching and treating it. So I think there definitely is a place for it, and it has helped some patients a lot. So this is something to ask about. If you've kind of gone through all these things and are still experiencing these symptoms, ask your provider if this is an option for you. But it is unfortunately only approved for hemodialysis currently. Hopefully down the line, they'll find different forms or different ways we can give it to peritoneal dialysis patients as well. So that's kind of been like my last effort go-to. However, we've been finding that using certain antidepressants has helped. We've also found this with neuropathy or nerve pain. So itching and nerve pain, sertraline's one that's been researched that we've seen. You do have to be on it for a few weeks, 4 to 6 weeks, to see if it's going to help at all. And, we do think that this does help. And I've had patients benefit from this. And we always start low on these doses. Again, lower requirement. It's always, the rule is start low dose and then you can titrate up. But we've seen some success too with certain antidepressants as well. So that's been promising too. So these were the last two things that it's given us a couple more tools besides, just go, make sure you put lotion on and keep the skin moisturized and, take Benadryl and sleep all the time. That's not a way to live. So we do go to these medications as well, if appropriate. Lastly, the UVB or ultraviolet B phototherapy, that's kind of a last. I had one patient do this, but he had itching before his kidney failure progressed. And it's something, dermatology, we refer out to them. But obviously with any UV light in our patients and increased risk of skin cancer and stuff, that's not something we really favor upon. Effectiveness is hit or miss. But it is something, in the end, it gets down to, do we want to try it or not? And that's a long discussion. And then ultimately, a lot of times for those patients that the itching just never resolves, if they get transplanted, we see it resolve after that. So that kind of tells us right there, it was some toxin that was causing that, that we just could not find or fix. So that is all of itching. Now that we're all itching from talking from itching. Moving on to cramping, I just want to touch on this briefly because this is one of those things, every dialysis patient you meet, I think will say, yeah, I've cramped at least once. I've never had a patient that cramps every treatment. I've had some that cramp frequently, but that's still kind of rare, but it can happen. The first thing we look at are the fluid gains. Are we pulling too much fluid in a treatment? Again, can one person handle only 2 liters of fluid, pulled in a treatment compared to another person who can handle 3 liters? So it can be the actual amount. It can also be we're pulling too low. You've gained true weight or real weight, and we're pulling you below your dry weight. So we need to adjust that. Shortening dialysis treatments where we're trying to pull the same amount of fluid in less time. That can contribute to that. I've had some patients we run most of our patients 4 hours, but sometimes we've had to go up to 4 hours, 15 minutes, and just having that extra 15 minutes, that allows us a little more time to pull fluid and eases and fixes some of the cramping issues for the severe cases. High salt intake again. So that's just another chime to follow a low salt diet. So treatment, looking at that, when the cramping occurs, we try to stretch the muscle. A lot of time you'll notice the techs or the staff or nurses, pushing back on the foot. If you're getting cramping in your calves, just trying to stretch the muscle to relieve that. We will turn down how fast we're removing water on the hemodialysis machine or change the rate on peritoneal dialysis. Decrease the total amount of fluid we're pulling for that treatment. If it's still not resolving, we'll give a little bit of extra saline to get the cramping resolved in the moment. Again, increase dialysis time, watching fluid restriction, keeping the fluid gains at goal between treatments. Again, low salt. And then this is where, whoops, I had an extra eye on dialysis there. Home dialysis, if it's an option. Sometimes when people go to peritoneal dialysis, it's gentler and it's more frequent. And that resolves cramping for those patients that cramp all the time on hemo, or even going from hemodialysis to home hemodialysis. That you get more frequent treatments, so you get more hours for the week, and that helps with that too. And with home hemo, there's some newer machines that are out. We're using one of the newer types, and the simplification of it, like it's a tablet and you can't really mess it up. It's step by step, and it will stop you if you load something incorrectly. So home hemo has been opened up, I think, to more patients and feeling more comfortable in doing that as well. So discussing if that's an option can sometimes help with that. Moving on to restless legs, the last thing, these are just the common symptoms. This is very common in kidney disease, especially dialysis. It gives you that urge that your legs need to move, or an aching feeling. This can increase at night, especially. A lot of patients complain that it bothers them at night and keeps them from sleeping. About 10% of the general population will get this. So this is non-kidney patients. Anywhere on the studies, you'll see 20 up to 75, 80% of chronic kidney disease or dialysis patients complain of this. And it's that irresistible urge to move your legs. And I've had acute episodes of this. And I would wake up at like 3 a.m. and I literally was doing lunges down my hallway just to ease it. That's what worked for me. It can occur at any time of day, but again, usually at night, sometimes just during dialysis. The first things we want to look at and make sure they're correct or corrected at goal are the iron stores. So looking at ferritin, iron saturation, hemoglobin, which are your red blood cells, which those should be monitored at least once, if not twice a month. Evaluate GI issues, if there's any absorption issues, if somebody's taking iron pills, We give IV iron in our units, and a lot of our patients about to start dialysis will do IV iron infusions because they just get the iron up and correct it, where the iron tablets, a lot of times at this point, they just don't do much, unfortunately. That is it. Okay, let's go to questions.
All right, just one comment. Sherry likes to use nutritional yeast, not brewer's yeast, for seasoning. She also recommends mint and lemon on green beans. And so I'm sure that sounds good to you, right, Mandy?
That's always helpful. And even though I'm a dietitian too, I'm not the best cook. So I look to my patients and I hear what they do and what tastes good. So those are good tips, and it's sharing and talking to
Yeah,
share.
back when you were talking about weight and fluid, I'm sorry, I don't have their name, but someone asked about home dialysis patients and how do they monitor weight and fluid?
So regardless if you're on peritoneal or home hemodialysis, you're provided a scale. And so you're weighing yourself just like you would at the unit and setting those goals, how much fluid to remove each treatment. So it's monitored the same way. The patient is just monitoring it and setting that for the machine. They're trained on how to do that.
I know Sherry says she put more questions in, but I helped answer one for her. She was asking about the salt solution that matches our salt, and I did respond that there's a sodium level on the machine that can be adjusted to match the sodium level in a patient's bloodstream. Is that correct?
That is correct. And I see your comment. So yes, that is something, and that's definitely a discussion between provider and patient and looking at that. It's very specialized.
And that's the only question. Other questions? You answered everything else. Thank you so much for being here, Mandy.
Thank you guys for having me. Whoop, there goes my computer again.
And a shout out to our corporate mission partners for making this happen.